Good evening and welcome all to the Wednesday evening webinar of Indian College of Anesthesiologists. This webinar is a special webinar. It's on the medico-legal dilemmas in our day-to-day practice. We often come into some sort of a problem where we find difficulty to come out easily, and we may resort to many other ways to get a proper reply as well as a proper remedial measure. In this webinar, the commonly seen problems or the areas where we want clarification further and further are being discussed through some of the eminent faculties in India. The chief moderating faculty is Dr. Sunila Sharma. Sunila Sharma is a senior consultant in anesthesiology. You know well about Dr. Sunila. She was the director X with the Fortis Hospital as well as with the Park Hospital, Delhi. Now she is taking an autumn break. She thinks she had done enough and she's in a break. I don't know for how many days this break will be there, but I'm sure she's not going to remain free because she is writing some textbooks on the medical legal practice, and the advice is what we should have. And she is going to be ably aided today by some of the legal luminaries, the advocates in the High Court of Delhi as well as in the Supreme Court, Dr. Geeta Mehrotra as well as Dr. Urvashi Popli, and our own friends, Harbhajan Saini, Pramod Kohli, and Dr. S.C. Parakh. All are good in their field. Not in the anesthesiology alone, because they are all legal opinion makers. For the last many years, they were advising and helping all our colleagues in problems. Now I request Dr. Sunila to take over this hybrid webinar. This is a different webinar, a slightly different from what we see on every Wednesday. Here there is presentation, as well as panel discussion, followed by question and answers. So Sunila will be introducing each speaker before they open up their discussion part. And Sunila, please take over.
Sunila, you have to unmute yourself if you're muted.
You have to unmute.
Okay, can you hear me now?
Yes, very much.
Yes.
Yeah, thank you so much for arranging this webinar. The demonstrate three things. What are the responsibilities of the anesthetist as far as the codes are concerned? They need to be well versed and up to date in specialty and have to give attention to details of the patient, drugs, machine, and monitor. Record keeping, and if they are stuck in some impending suit, minimum talking. And to the complainant, there has to be concise and factual explanation right from the time that the patient, who is a complainant, or that they come in contact with the anesthesiologist. So I'll be talking about what kinds of difficulties anesthetists can get into, result in lawsuits, and how to minimize the chances of having such lawsuits to occur. Though we know that any one of us who practice any branch of medicine may be sued, no one can stop a patient from doing so if he or she wants to, whether there are any grounds for action or not. Most of the time, the complainant has just a grievance because of the doctor's carelessness or lack of attention to detail during handling the case. So, the doctor is expected to possess and use a reasonable degree of learning and skill, as is expected from an average doctor in any district. Use his best judgments while keeping abreast of the times and follow the approved methods for pre-anesthetic checkup, choice of anesthesia, and even supervising his juniors. So I can share my screen with my presentation. the medico-legal aspects of anesthesia. Oh no, this is for Geeta Mehrotra. So probably this is not what I must be sharing. You should just pass it on to me, the lawyer. No. Then where is mine? Informed consent and webinar medico-legal MS. This is Dr. Kohli's. Oh my God, I seem to have opened all, but not mine. And a panel discussion I've opened. So let me get it from my screen. If you can excuse me for a second, I'll minimize it and get it from my screen. So my medical legal aspects of there I've got anesthesia. Oh no, again she's coming. I've actually got all confused. Just a minute because they have been. This is for the panel discussion which we'll be having a little later. Oh my God, where is it? Webinar medical legal dilemmas in anesthesia practice. I've got so many things over it. Suddenly I got that. Well, webinar, medical legal. Oh my God, what is happening? No, this is webinar. I must stop it. I'm getting into problem. On medical dilemmas in anesthesia practice. Okay. Hmm. Well, I'll be talking a little about the medical legal dilemmas in anesthesia practice. Well, any one of us who practices in any branch of medicine can be sued. No one can stop a patient from doing so if he or she wants to, whether there are any grounds for the action or not. Most of the times, the complainant has just a grievance because of doctor's carelessness or lack of attention to detail during handling of the case. Well, from legal point of view, there are expected duties and care from the anesthesiologist in the practice that he or she does. The pre-anesthetic evaluation is very important. We all know that we have to know our patient for medical illnesses and surgical fitness. The preoperative communication with the patient and the relatives is essential. It's not that a junior is sent and the senior hasn't seen and the senior is conducting a case, the patient doesn't recognize the anesthetist. That's not a good thing to do. So the communication about the choice of the anesthetic technique, the possibility of even damage or displacement of the teeth crowns or bridgework during difficult endotracheal intubation, the type of anesthesia that is planned for the surgical procedure, and possibility of conversion of the anesthetic technique from spinal or epidural block to general anesthesia if the surgery is prolonged. So it is a duty of the anesthetist to check the equipment, including oxygen, gas cylinder, anesthetic machine, prior to the operation and ensure that there is a backup resuscitation kit with defibrillator, ambu bag, and mask, so that in case of malfunction of equipment or cardiac arrest, the things are not haywire. The anesthesiologist must know when to avoid original blocks, especially in patients who have got a neurological disease. Nobody wants to land up in a problem of paresis or paralysis. So they have to be really well-read and could consult the other consultants if they are in doubt. They should ensure that the nerve block that they give is safe, effective, and useful. And they constantly are vigilant of, for the patient during anesthesia while monitoring the vital signs, because there is a trend that since they are long procedures and the anesthesia has become so safe that people forget they are inside the OTs with their novels and they are reading something else and they can miss, and the catastrophe may happen anytime because they may miss that the endotracheal tube has misplaced. So there can be hypoxic damage, which constitutes medical negligence. So constant vigilance during the surgical procedure by the anesthesiologist on duty for that case is the key to prevent and instantly treat intraoperative adverse events. And awareness during anesthesia is also a cause of concern for the surgical patients, which attracts allegations of mental stress due to inadequate anesthesia. This slide with all its content has been shared by Ms. Geeta Mehrotra, who is a practicing advocate. So we know that the responsibilities of anesthesiologists, as far as courts are concerned, is to be well versed and up to date in specialty. They should have good communication skills. They have to explain the concise and factual facts to the patient, who later becomes a complainant. They have to give attention to the details of the patient. Consent. Don't send only your juniors to do it for it. The communication during consent with the patient and the relatives is very, very important. Drugs, machine, and monitors have to be checked for patient safety before starting the case. The conduct of anesthesia, the choice of technique, you have to again tell the patient, and the patient should agree for it. And if not, you should be able to convince if you think that that is safer. Documentation is the most important thing, and that should be well done then, in a haphazard manner, or in a way when it can't be read, especially if any day a legal case is filed. Records are the only things which help you in during the case, and there should be minimum talking during impending suit if somebody sues you. The communication skills are very important, and anesthetists have to do it during pre-anesthetic evaluation, taking a consent. Don't depend for the consent for the nurse to take it, or a junior resident or him to do it. You should take the consent yourself. So that is important. So induction of anesthesia. Oh my God, power is not going down. Wait a minute, just give me a second. I'm so sorry. This is not switching off. I don't know why. Sorry. Power shut down. Okay, done. So communication skills, as I said, pre-anesthetic evaluation, consent, induction of anesthesia, everywhere you have to really either pacify the patient if he's too afraid to undergo the knife, and also interpretively when the patient is under regional anesthesia. And remember, don't forget the postoperative care. Must visit the patient once or twice after that. Now, these are few questions which will be actually, since we are having the panel discussion also. So I have put in few questions which will be to the panelists, which will be Dr. Kohli uh, on consent. Then again, this is for, because Dr. Kohli is legal expert, the lawyer practicing. Desired documentation that is required of everything that we do, right from pre-anesthetic checkup to the procedure we perform, post-operative follow-up, any complications that occur, and post-operatively, and how do we treat. Even they say you must keep records of the daily business in the hospital that you do. That means you should have the record of your own patients with you. So quality of work is very important, and there is, I think that there are other talks about it. You have to be really well experienced, and you should not leave the operation theater on a junior resident or on a technician to go and have a cup of tea. I think that is what has led to many accidents. There have been cases when the anesthetist being this a routine work have been seen reading novels while not looking at the monitors. So quality of work and the documentation is very important to have the safety in anesthesia. Well, as we later will be going on ethical dilemmas also in one of the panel discussions. So we will discuss about DNR, palliation, elderly with life-threatening disease, rationing of treatment in terminal illnesses, end-of-life care, unwanted care in ICU, harassment and desired work compensation. So we will have the panelists in our next session, I think, so once we have done it. And these are our panelists. I'll be moderating. Dr. Pramod Kohli, who is a surgeon and medical legal consultant, Dr. Shyam Parakh, anesthesiologist with LLM in international law. Dr. Harbhajan Saini from Bhopal, who is an HOD anesthesiology. I don't know whether Urvashi Popli has been able to join with Geeta Mehrotra. These are the two advocates. So let's see that they'll be able to help us. So we have put in certain questions, and during the panel discussion, these questions will be, asked to different panelists. So I think I will thank you for your, for allowing me to do that. And whenever we have to start the panel discussion, can we do it right now? Would the organizers want me to do it right now, or we wait for that panel discussion? I'm not getting any reply.
Hello, whichever way you plan, you can go ahead.
Okay, so before I go, there are 4 or 5 slides I made. I think the Geeta Mehrotra, who is an advocate, he made for me. So I thought I must share that also. I'll just put it on the slideshow. Uh, Expected duties and care from the anesthesiologist. What is the legal view? And pre-anesthetic evaluation is very important. We know that we all do it and it's mandatory, but don't just leave it on the juniors. It should be a senior should go and review and talk to the patient and the relatives. That's very important. Consent and all should not be customary, which should be given to the nurse or somebody to do it for you. It's much better that the doctors can do it themselves, so that raises the faith that a doctor, the patient's relatives have with the doctor. So preoperative communication, we all know that we must talk about the choice of the anesthetic technique, even the possibility of damage or displacement of the teeth, crowns or bridge work, if the endotracheal intubation is difficult, the type of anesthesia that we've planned for the surgical procedure, and even the possibility of conversion of the anesthetic technique from spinal or original block to general anesthesia if the surgery gets prolonged and we don't have the backup of the epidural catheter. Possibility of occurrence of post-operative headaches after spinal epidural, and precautions to prevent it should be undertaken, and even in preoperative communication could be mentioned. Checking of the equipment, it is much better not to leave that only on the technicians who assist you, because oxygen gas cylinder and anesthetic machine prior to operation have to be checked, and ensure that there's a backup resuscitating kit with defibrillator, ambu bag and mask everywhere, so that in case of malfunction of the equipment or during the procedure or cardiac arrest, you've got everything around you. The anesthetist must avoid regional blocks in all types of patients who have got neurological and defective blood coagulation diseases, and ensure that the nerve block is safe, effective, and useful in patients whom they are giving it. Constant vigilance is the motto of the doctor for the patient during anesthesia, and monitoring of the vital signs has to be done diligently by the anesthesiologist to prevent and instantly treat intraoperative adverse events. They must be able to detect misplacement of an endotracheal tube before there is hypoxic damage. So this is what is negligence. Prevention of awareness during anesthesia, also the steps to be taken to avoid allegation of mental stress due to inadequate anesthesia. So we had, when can the anesthesiologist be held liable for medical negligence in situations when the faulty equipments were not detected prior to operation, or when there was a failure to make constant vigilance and minimum monitoring during the period of anesthesia. There was minimum monitoring. So there was a case when the National Commission held that there was medical negligence on the part of the doctor on count of in giving anesthesia, because when the spinal cord was injected wrongly, leading to numbness in the legs of the patient, and patient was not fully cured because there was a residual paralysis that stayed on after a spinal anesthetic. So this is the in 2020, recently, just not less than a year ago, this case happened. So the anesthesiologist was held responsible. Again, we many times find that the consent form is left blank or again left for the nurses to get it filled. And so this was a case which again happened in 2020. A national commission held that since the consent form is blank with respect to columns explaining risks and the doctor did not disclose the nature and procedure of treatment, therefore it is lack of informed consent and held liable to the hospital, held the hospital liable to the negligence along with the doctor. Well, there are many cases when a doctrine of res ipsa loquitur is established. That means that the thing speaks for itself. Like when the patient whose all parameters are normal and who walked to the operation theatre for treatment for a simple ailment, but within an hour she was declared dead. Why? Whether there was an inadvertent extubation or what happened, that actually is for the doctors to explain, and it's a very difficult to get through that. Well, I think that is the end of my uh, uh, consent form was blank. No, I have got why didn't it come? Medical activity. I have got this some things from I think from Geeta, who is a legal expert. I don't know whether Geeta has joined us. I gave her the time. So I will just speak her few things. As I've already said that there are some expected duties from for the anesthesiologist, which we all know and try to do it to the best of our thing. And vigilance is very, very important. Preoperative communication with the patient and the relatives is very, very essential. Telling them the choice of anesthetic technique, possibility of damage or displacement of the teeth, crowns, and bridgework, because they are very costly, and people have sued the doctors for that. Again, anesthesia type and conversion of the anesthetic technique from spinal or epidural to general if surgery gets prolonged. Post-operative headache. So checking the equipment, as I said before, is very, very important. And anesthesiologists must avoid regional blocks in all types of patients with neurological and defective blood coagulation diseases. Constant vigilance is important. And the anesthetist must detect the misplacement of an endotracheal tube before the hypoxic damage occurs. That means you don't leave it on a technician, go for a cup of tea or something. Leave it to somebody responsible who will monitor the patient. Prevention of awareness during anesthesia to avoid allegations of mental stress due to inadequate anesthesia. So when the faulty equipments are not detected prior to operation or there's a failure to make constant vigil and minimum monitoring during the period of anesthesia, the anesthesiologist can be held liable for medical negligence. So in 2020, there was a case, Mahatma Gandhi Hospital and another versus Chavi Goel. A national commission held that there was medical negligence on the part of doctor and hospital on the count of giving anesthesia through spinal because what happened is there was probably the spinal cord was injured and it led to numbness in the legs of the patient and the patient was not fully cured. This has been recently reported in CPJ. Again, there was another case where the consent form was blank. So National Commission held that since the consent form is blank with respect to columns explaining risks and doctor did not disclose the nature and procedures of the treatment, therefore it is lack of informed consent and doctor was held liable to the hospital and both actually the doctor and the hospital were held liable. Res ipsa loquitur, we all know that the thing speaks for itself because the patient who walks normal and walks to the operation theatre for treatment for a simple ailment and within an hour that patient is declared dead. So it is for the doctors who are there to explain what went wrong that caused the death of the patient. It could be probably massive hemorrhage due to a surgical thing, but it has to be really documented. So I think then is it was my advocate who wanted to be who is going to be with us in the panel discussion. So I think I will let that be for that time. So I think I'll finish my oration here. Whatever I speak, if there are any questions, I'm ready to take. These questions I'll be asking to at the time of panel discussion. Thank you. Am I audible? Hello?
Thank
Yes.
you, Dr. Sunila Sharma, for giving all this information which I had shared with you on legal aspect also.
Yeah,
And
I
recent judgment you have quoted the recent judgment which I have provided to you,
that's
and
right.
these are very important.
That's right.
How the anesthetist has to be vigilant about all the things, machinery as well as explanation to the patients and relatives.
That's right. Thank you for your contribution. I really
Also, thank you.
yeah, we can give it back to the organ.
Question, then I can give the answer at the time which has been allocated.
Yeah, we will have some panel discussions. So during that time, we will see that we could take some questions. That might interest the audience. Yeah, thank you,
I
Dr.
may
Radhakrishnan.
confine myself in respect of the anesthesia only.
Yeah, because it is a conference for the
Yeah.
anesthesiologists. Yeah.
Yeah.
Before the panel opens, whether Dr. Harbhajan and Dr. Pramod Kohli and Dr. Parakh, if do they want to present anything, they can go ahead.
Yes, I think Dr. Kohli wanted to present on consent and medical documentation.
Okay.
Dr. Kohli, are you with us?
Yes, yes, I'm
Yeah,
there.
please,
Yeah.
please.
Okay, thank you. I must thank the organizers for giving me this opportunity. I was asked to clear some queries which are generally asked from the medical legal point of view based on consent and documentation. So my topic is, although relatively simpler, but it's a very important topic because many of the litigations are based on consent and documentation. So the first question is, who is responsible for consent before a surgical procedure? Surgeon or anesthetist? Treating physician under whom the patient is admitted is mainly responsible for the consent. When it is a question of a consent for a procedure, the person conducting the procedure is responsible for the consent. For anesthesia consent, the anesthetist in charge is responsible for the anesthesia consent. Anesthesia consent should be taken independent of the surgery consent. Consent is a legal doctrine. It's not just a paper with the patient's signatures on it. Many a times we see in the wards that the junior most nurse or even the GDA is sent to take signatures on the consent form, and he just goes there, and whosoever is present there in the patient's bedside, he takes his signatures. He doesn't know where exactly the signature should be put in, whether he's the right person to put in those signatures. We should take consent very seriously because it has three very important steps: discussion, decision, and documentation. The discussion is between the doctor who performs and the patient and his relatives. The discussion entails providing relevant information on the subject, on the procedure, on the other related issues to the patient and the well-wishers. After the discussion, the patient has to take a decision. Whether he takes a decision in favor of the procedure or against, he might take some more time to decide. He might like to discuss with his well-wishers. He might like to seek second opinions. He might like to do some Google research, or he might want to come back to you for further clarifications. So after that, he may take a decision in favor of the procedure, or he may like to avoid the procedure, or he may attach some conditions to the procedure. He might say, you remove my fibroid, but please don't remove my uterus. Or he might say, you can resect my intestine, but please don't do any ostomy. So whatever he decides, the doctor has to then take his own decision. The third component is the documentation. In the good old days, documentation was not very important because that time the doctor-patient relationship was based on trust. And as we know, legally speaking, even oral consent is valid. But in today's context, when the relationship between doctors and patients is more contractual than fiduciary, and the litigations are very common, documentation becomes a very important component of this consent because oral consents are difficult to prove. The next question that is commonly asked is how much of the risks should be disclosed to the patient? This is a very tricky situation which is quite debatable, and I'll be a little more elaborate on this. Requisite info for surgery consent should include nature and gravity of the illness and comorbidities that the patient is suffering, nature of the surgery contemplated, any alternative options, including, oh, my screen has gone off. Any alternative options, including the no treatment option with pros and cons, probable risks and possible extension of the procedure, estimated surgery time, recovery time, hospitalization time, estimated expenses involved, and any other doubt, query, or clarification, which means opportunity to ask questions. Similarly, requisite info for anesthesia consent should include nature and gravity of the illness and comorbidities that the patient is suffering, nature of the surgery contemplated, ASA grade, airway status, and any anticipated difficulties and risks, type of anesthesia contemplated, and possible alterations that may be needed, protocols for intra and post-operative monitoring and care, routine recovery room stay and possible ICU stay, and any other doubt, query, or clarification that is opportunity to ask questions. Now, the pertinent question is how much of the risks should be disclosed to the patient? For this, we need to understand what is known as prudent person rule. And in our context, this prudent person could be a prudent patient or a prudent doctor. When we talk of prudent patient principle, it means that we tell all that a prudent patient would like to know from his doctor. Generally, the patient wants to know everything, even the remote risks. This is the US practice. The consent document in US is quite elaborate, and it's more like a booklet, and this contains all the information about all the types of risks and the possible complications, the mortality, morbidity data, the statistics, national statistics, the institutional statistics, and statistics related to that particular surgeon. So the patient wants to know everything, and that is the US practice, and this is called informed consent. Here, informed is used as a noun when we say informed consent in the US context. On the other hand, a prudent doctor principle means you tell all that a prudent doctor would like his patient to know to make an informed choice. Generally, the doctor likes to tell the main risks only, and this is the UK practice. This is also called real consent. In Indian courts, it's usually the UK practice that is followed. And the Supreme Court of India has, in a number of judgments, clarified this position. And the main judgment, in my mind, is Samira Kohli versus Dr. Prabha Manchanda. And I'd request everybody to go through that judgment at least once. This is very elaborate judgment on consent in medical practice. And the Supreme Court has held there is no need to explain remote or theoretical risks involved, which may frighten or confuse a patient, causing refusal of a necessary treatment. Similarly, there is no need to explain a remote or theoretical risks of refusal of surgery in order to persuade him to undergo an unnecessary treatment. By and large, we follow this practice. Now, who should discuss the details for taking the consent? The person in charge of the case and who takes medical decisions is responsible for providing the relevant information to the patient to enable him to give informed consent and to answer his queries. Surgeon cannot substitute for the anesthetist, as these are different specialties with different set of procedures and risks, and there are different queries and apprehensions in the minds of the patient. So anesthesia consent has to be separately taken and should not be combined with surgery consent. What if the consent has not been taken or there is no valid informed consent on the records? Surgery without valid consent legally amounts to actionable assault by the doctor on the patient under criminal law, deficiency of service under civil and consumer law. Who should sign the consent form from the patient side? Patient himself, if he is competent to consent, that is, he is conscious, adult, of sound mind, not under influence of intoxicating drugs. Next of kin, if the patient himself is not competent to consent. The next of kin could mean the spouse, the parents, the adult children, or the brother, sister, siblings. For life-saving procedure, no consent is required. Additional assent is admissible in case of older children with reasonable understanding. For what period is the consent valid? Generally for 24 hours. However, if significant time has elapsed between the consent and the timing of the procedure, or if material changes have occurred in the circumstances of the case, the consent should be reviewed and taken again. Can consent be withdrawn? Yes, the patient has all the freedom. Patient can seek more time to think, discuss, and decide. Patient can give conditional consent. Patient has a right to withdraw the consent anytime after giving it. Patient is not duty bound to give any reasons for his decision. What is therapeutic privilege or doctrine of necessity? Doctor has the privilege and a duty to provide the necessary treatment even without any consent when the situation is life-threatening and a life-saving procedure is needed. The patient is not in a position to give a valid consent. There is no relative or guardian available. Also, in persons suffering from a notifiable disease, prisoners, examination under court order, or on the request of police under section 53(1) of CRPC, no consent is needed. What to do if one is required to alter the procedure from what has been contemplated? If during the surgery an additional or different procedure is deemed necessary, do it if specific consent has already been taken from the patient. Take the consent from the proxy if proxy has already been appointed by the patient. Conclude the procedure, allow the patient to become competent to consent, discuss the details with him, and perform if he now consents. For a life-saving procedure, all above can be ignored. Now, which anesthesia documents are medico-legally very important? These are some of the documents which are very important. If they are well written, it gives us a good defense. If they're not well written or they're not available, then our defense crumbles. PAC and review PAC, anesthesia monitoring charts, surgical safety checklist, recovery room notes, transfer notes, notes on SOS calls from different parts of the hospital, and COVID-related consent and undertaking. Why is documentation so important in litigation? Documentation is important medically as well as medico-legally. Medically, we all know we have been taught and trained during our undergraduate and postgraduate curriculum. It's important for continuity of care and for various statistics, for research and so on. Medico-legally also it's very important. Legally, documentation helps us in substantiating our contention and in rebutting the allegations. Medical records are considered to be the most important evidence by the courts in medical litigation, unless they are fabricated. Moreover, medical records are created by us. We can draft our sentences the way we want. We can put in some line diagrams if we want. They remain in our custody. So there is no reason why we should not take them seriously and make them prudently. Thank you. I'll take up other queries if there are any in the Q&A session. Dr. Sunila?
Yeah.
We will do the queries later.
Yeah.
Let Harbhajan Singh go ahead with his presentation. Saini, please.
Sir, I think there has been some misunderstanding. I haven't have made any presentation,
No, you
but
can.
I volunteered to take any questions from the experts or from the audience.
Okay. Then in that case, Dr. Shyam, Parakh, you like to present anything? Shyam, Parakh,
Shyam Parakh.
Parakh, please unmute. Please unmute.
Now, can you hear me now?
Yes, yes, we can hear you.
Yeah, I just want to add one point to whatever has been said about documentation of a consent. So it is very obvious to everybody that anesthetist should sign the consent and the patient should sign, or somebody on behalf of the patient should sign. But I have found it very useful and practical to get a witness sign on that, because witness is very important when documents go to court. And I always prefer the person who accompanies the patient to sign as a witness. Because in a mishap, most probably when patient is not there, he will only create the problem. So if we have his signatures there, at least to the part of consent, he cannot deny. And he will always be hesitant because he has signed the document, he will not go to court probably. So we must insist that the person accompanying the patient signs as a witness. Thank you.
Dr. Kohli, thank you
Yes.
for giving this information, but I want to add one thing more. If anything has been left blank, the court has held that this is not a proper informed consent.
Absolutely. That's very correct, because many a times we find.
And supply, although this is the responsibility of the hospital, that if the documents have not been supplied, reports have not been supplied to the patient, it is also a deficiency in service.
Absolutely. See, the blank consent form is not only a deficiency of service, but it might amount to cheating, because many a
Yes.
times we find that the junior most nurse goes there and gets the signatures on the blank
Yes.
form, and we have seen cases where in the courts that blank form with full signatures are there, but the basics are not there. Yeah.
There is a recent judgment of 2020 where National Commissioner has held that the surgeon or an anesthetist should make themselves the entry in the consent form. What procedure, what treatment is given to the patient.
Yeah, exactly. See,
Huh.
what we recommend is that the form may be filled by anybody, the resident or the nurse, but the
But-
name of the patient, name of the surgery, and the risks should be filled by the surgeon himself, and the
Yes.
surgeon should also sign. The
Yes.
signing by the surgeon on the surgery consent and signing by the anesthetist on anesthesia consent means that that surgeon has communicated all the requisite information himself to the patient and the relatives.
Yes.
Yeah.
And this point has been dealt with by the National Commission in 2020. I can give the citation, volume 2, 2020, CPJ, page 68.
Right.
This is a recent judgment.
Agreed.
Something else which has come recently, especially in the National Commission, that written consent only is going to be accepted, not the printed consent. You have any knowledge on this particular matter? Then we are all using printed consent form. We will make the patient sign. But now there is a court order which has come up, which I heard from the National Commission, that it should be written consent, and the documented consent or the printed consent is not that valid. Any idea on this particular matter?
See, yeah, I am also aware of this judgment. It's difficult, practically difficult to have handwritten consent in all cases. And what can be defended is that you have a printed form, but the main material aspects are handwritten, particularly the name of the patient, the age, the sex, the name of the procedure should be properly written. The risks should be mentioned, preferably handwritten, because every surgery will have different set of risks, and every patient will be differently vulnerable. And then some important areas where you are contemplating removal of an organ or removal of a limb, that component should be handwritten. So where it's not possible to have every consent to be handwritten, the material aspects of important consents should preferably be handwritten. And where the handwritten note has been made, you should have the signatures of the patient there also, not only at the end of the consent document, but also in the area where you've made a handwritten note. So that can be defended.
Yes, so that they cannot take advantage that it has been tampered.
Absolutely, yeah.
But if this court decision has to be done, well, I am doing a surgery or I am doing anesthesia. I may have to change the anesthetic sequence to something else. Or a surgeon has to see that an amputation or removal of an organ has to be done immediately. Well, in that case, will it come under therapeutic privilege?
It will come under therapeutic privilege only if it is a life-saving procedure. And it will come under therapeutic privilege only to the extent of that life-saving procedure only. Otherwise, that Samira Kohli versus Prabha Manchanda, that judgment by the Supreme Court has elaborated that you cannot do any procedure, any extension of the procedure beyond what has been consented to, unless it is life-saving. The alternative that we recommend is you take a proxy consent when the patient gives a surgery consent, so that he writes, when I am under anesthesia, I authorize such and such person to take decisions on my behalf. So if a valid proxy consent has been taken, then at the time of surgery, when some alteration has to be done, you can take the consent from that proxy. But otherwise, the court recommends that you, complete the procedure, take him out of anesthesia, discuss the extended procedure with him, and go in again if he consents for it.
So may I make a comment here?
Yeah.
The practice of having a blanket consent is what gives rise to so many problems in the court later on. To give you an example, you have a patient coming with pain abdomen, you diagnose an appendicitis, and you plan to do a removal of an appendix in this patient. Now, as per law, you are supposed to remove only the appendix for this patient. Now, if at the time of initial examination, the surgeon has seen that the patient has already undergone 2 surgeries earlier, and he expects that yes, there may be adhesions inside, and in addition to removing the appendix, he might have to remove the adhesions first and then gain an access to the appendicular area. So this anticipation helps you to explain all the likely and unlikely things which you're likely to face once you open the abdomen. So just taking a blanket consent that you are allowing the surgeon to do whatever he feels like is right is not the whole correct thing. Basically, every surgeon should be good at anticipating what are the likely unknown things that can happen in this patient that he might have to intervene and explain them and take a consent for that. So then the things will become easier. Now, suppose you say that this is an appendicitis and it is a virgin abdomen. So you are very sure that I'm just going to go in, remove the appendix and come out. But if there are 2 or 3 surgeries done earlier, then you will have to do adhesiolysis. And maybe if it has been a very long-standing disease, the gut is not in a good condition, you might have to, you might end up removing a part of the gut and doing a resection, anastomosis, and coming out. So the wisdom lies in anticipating what are the additional things which you might be doing and explaining them to the patient at the time of consent. This is one step which every surgeon takes, will reduce the amount of litigation which we face in our practice. This is the surgical point of view. Now, similarly, the anesthesia point of view, what is important is that you need to understand what the patient expects from you. For a patient, a doctor is just a service provider. This is the brutal reality of our world. We are supposed to give him a service, and that is to their satisfaction. So we may do a very good job, but if it is not to their satisfaction, this is going to create some smoke here and there. So as an anesthetist, you need to be very clear what the patient is expecting. Now, the other thing that you need to anticipate is whenever you are taking up any patient for anesthesia is whether you will be able to have a peripheral venous access for this patient or not, or whether you will have to go for a central line in this patient. Let's say you have a patient who is very fat, or a patient who has undergone a lot of chemotherapy from a peripheral venous line, and this patient is coming for a major surgery, and you do not explain to the patient that, see, I'll try a peripheral venous access. If it is good, fine. But if it is not, I will put in a central line. Now, putting a central line is a much more invasive procedure than putting in a peripheral IV line. So if you have explained these things to the patient and taken a consent and you go ahead with it, then you are protected. But if you haven't, then trust me that it is going to lead to a litigation, because doing an invasive procedure without consent is a damage being done to the patient, no matter how medically it may be right. I cannot give anesthesia if I do not have IV access to the patient. So medically I'm right, but if I have not taken the consent, I'm wrong. And God forbid, while putting in a central line, if you happen to damage a vessel requiring a cardiac surgeon to intervene, or a surgeon to put in a chest tube, you had it. So basically, the biggest step that we need to take of both the surgeon and the anesthetist is anticipate what you think can go wrong in the patient, explain them in detail. It's always better to explain more and perform under, and stay away from problems.
Harbhajan, it seems to be slightly complicated. See, do you want me to take consent, do a peripheral cannulation? Do I need to take the consent of the patient to do a peripheral cannulation? Because every patient, when admitted to a hospital, he or she may have to give a consent in the hospital form that, well, patient has no objection for the procedures which are being done for the benefit of the patient. There is a blanket consent like that. Now, more than that, do you think even for peripheral cannulation, a certain consent has to be raised?
Sir, all the steps of the care that you are going to provide should be explained to the patient, some in brief, some in detail, and we should have a consent for all of them. If you have a patient with a difficult venous access, patient is very fat, is diabetic, veins are not good, they are tortuous, and you end up pricking 10 times, this patient is not going to be happy with you. But if you have explained him, trust me, sir, this patient will not make a noise. So it's always better to explain to the patient in case you are planning to do an intervention which is likely to cause some discomfort and some dissatisfaction to the patient. It's always better.
If that's all there, we can always give the explanation to the patient. But in the present day technological age, well, we can have the ultrasound blocking and we can see the vein and you may be able to cannulate. If not, sometimes you may go to a cut down. In that case also, the way you say, well, we have to take permission for it. Well, I may be trying. If I am not able to get, I may use the ultrasound, or I may sometimes even resort to cut down. Do you think a stepwise consent is necessary?
Sir, one should always be patient specific. In a patient wherein you think that your venous cannulation is going to be easy, straightforward, maybe you can omit it. But in a high risk patient, in a high profile patient, in a patient who you anticipate at the time of your pre-anesthetic checkup or an interview that is going to be a problematic, the person who is asking a lot of questions, especially the Google patients, it's always better to be little more explicit. This is my personal opinion.
Parakh, do you agree or do you differ from these particular opinions?
Pardon, sir, I didn't hear you right.
No, we said in the beginning, or I mean, Kohli was saying in the beginning that we are all.
So you are not audible. So I'm not able to understand what you're saying.
No,
It's ongoing.
Pramod Kohli was telling in the beginning that we are following the doctrine.
I'm unable to hear you.
Yeah, I have understood the question. See, the remote risks, the remote issues can be left as such. In a routine surgery, you've taken the consent for the actual procedure. The other things go along with it. The IV line goes along with it. So I don't think you have to take consent for every step of the procedure. The remote complications, the remote risks can be avoided, but the common risks have to be explained. And secondly, apart from explaining, they have to be documented. So where you think the possibility of central line is more, then of course you take the consent for central line also and document it in the consent form.
Dr. Sunila,
Yeah.
Discussion questions. Will you go ahead?
Do I need?
Will you go with your panel questions?
Yeah, panel questions. I'll go. I'll just open that. Just give me a second. Am I audible?
Yeah.
Yeah, I'll just, it is some medico-legal dilemmas in anesthesia practice. And the panelist, I'm going to be a moderator. Dr. Pramod Kohli, who is a surgeon and medico-legal consultant, is one of the members. Dr. Shyam Parakh, he's an anesthesiologist with LLM in international law. Dr. Harbhajan Saini, who is an HOD anesthesiology at Bhopal. Miss Geeta Mehrotra is an advocate. I don't find Urvashi Popli joined us, so I think Geeta Mehrotra will join us as a panelist. So topics for discussion, informed consent and desired documentation are from Dr. Kohli. So Dr. Kohli?
No, I've already
Yeah.
dealt with all the questions. I mean, if there are more questions on consent and documentation, I'll take them up.
That's right.
I think you have covered all the things.
Yes.
Thank you, Dr. Kohli.
Majority
Yeah,
of difficult
So
questions.
that has been taken over. Dr. Shyam Parakh, you had communication skills and ethical dilemmas, because there'll be more questions coming up to common questions also that that are given to me. So do you want to do some talk something about communication skills and ethical dilemmas?
See, the thing is, if you go question answer, it's okay. Otherwise, I will tell you that this litigation problem is mainly because of lack of communication.
yes.
I always tell the people that litigation is not because of the mishap that has happened. Because even court says that medicine is an inexact science. So nobody expects 100% cure. But it is mainly because of lack of communication. Because patient has not been communicated beforehand what can go wrong. So if we do a proper communication, the main thing is patient will be mentally prepared and anticipate that these things can happen. The main problem is there is no communication, and to patient it comes all from a blue. That people go out and say, now your patient is not good, he has suffered some heart attack or something. But if we spend some time with the patient, of course, people are very busy and for per patient, they don't have much time. But then if you want to really avoid litigation, you have to give adequate time to the person, talk to him. And communication is a two-way procedure. So you have to more. You listen to the patient more and then you answer, because every patient wants to know different things. The information cannot be same for everybody. You have to make it tailor-made. So what the patient, once you start talking, then the patient responds, then you know what he really wants to know. And once you explain everything to their satisfaction, then most of the problems will not come. So this, unfortunately, this communication skill it is cannot be taught. It has to be learned by people, and it's not a theory. It is a practice that people have to do. So by doing it, observing some people who are really good at communication, talking to the patient, then our junior residents can learn how to talk to the patient, how to deal with them. So that is very important thing. So a good communication will almost 99% of the problems will be avoided. There's no
Yes,
doubt. Yes, any more question?
Another question in this context, everybody can answer. Well, whether a patient getting treatment in a government facility, that means in government facility, well, we presume all the services are free, except very few services are chargeable, because most of the services what we get are free. Whereas in a corporate hospital or a private facility, well, you are charged for everything what you receive from there. Which of the patient can go to the consumer court?
Sir,
Whether a patient he also can go for a consumer court, or
whom do you want to answer?
anybody can answer.
Okay, then let me tell you. Way back in VP Shanta versus IMA, the Supreme Court had very clearly said it, that all the institutions can be classified into three types. So one are those who are doing 100% free work. And there is no doubt that these people, patients from that institution do not come under Consumer Protection Act. And others are, like you said, corporate hospitals who treat everybody on payment. And there also, there is no doubt that every patient there comes under Consumer Protection Act. So third category is who do part work on payment, part work on free. So there it clarified that these institutions will also come under Consumer Protection Act because some other patients are paying for them. Although the patient himself is not paying, but the paying patients are paying. Or same analogy, even if insurance is paying or some other trust is paying, patient may not directly pay, but somebody is paying on his behalf. So that's why those patients will come take advantage of consumer courts, because it said otherwise we'll not be doing that. The very purpose of Consumer Act will be defeated, because if these poor people are not allowed access to the consumer courts, then the purpose will be defeated. So this has been made very clear in this VP Shanta case. Now there is no doubt about it.
It was long back.
Yeah.
VP Shanta versus the Union.
Yeah.
It was long back.
But that has not been changed. That ruling stays.
How about now? I would like to have Dr. Geeta's opinion on the matter. Dr. Geeta, is there any change?
Dr. Geeta, please.
Pardon?
Hello, on this particular matter, because Dr. Parakh was telling that
yes,
100%.
Your voice is is not clear. It's breaking.
Okay, I'll try to improve.
Dr.
Hello.
He said that the court has held if the hospital charge for some patients and some patients are treated free, then the hospital comes and doctor serving there also comes under consumer courts, Consumer Act.
You mean a free treatment facility will not come under consumer courts?
Total free, sir. If it is doing only free service, it will not come under court.
Only free service.
That will not come under that consumer court.
But if they're doing some nonsense there, if they're doing some nonsense.
Why is breaking?
No, it's sir. We forget that ordinary courts are
Your
still
voice
there.
is breaking.
If the
I am not able to understand what you are.
Okay. 1 minute, madam. Geeta, madam, 1 minute. So the thing is,
is also
Other remedies are still there. Even if consumer court access is not there, they can go to ordinary courts. And one more thing I will add is that there is no question of government or private. Even in government, when there are private paying wards, then even that government hospital will come under Consumer Protection Act. It's a matter of payment, not of government or
yes,
private.
yes.
See, there are a lot of cases being done
If you are
against.
providing the services after taking the
There are a lot of cases against AIMS and PGI Chandigarh, Rohtak Medical College, all government hospitals.
there is one case of Safdarjung Hospital
Yeah.
on this point.
Not only cases are there, already compensation has been awarded and government has to pay.
Yes, yes. The doctor has taken the plea that he has not charged anything from the patient. Even then the consumer court has granted the compensation. Holding that he is the consumer.
That V. Shantaram judgment is still applicable. Nobody has challenged that decision. So as long as it is there, we have to abide by that. Dr. Sunila, we can open it to the audience. I mean, if the audience wants to ask some questions.
Yeah, there were some questions that were also created.
No, Sunila, 1 minute. You please finish with your those 15 questions and then open it to for
I think it will be much better that way.
Yeah.
Because I think the first, let me just share the question one by one while the answer goes after that. The first question is, whosoever the panelist wants to do it, who is responsible for a consent before a surgical procedure?
That has been discussed.
That has been discussed. Written consent. It is not the, and it is probably not the nurse who is going and just told to get it signed. That is something very. Now, suppose there's a death on table. And when is DOT consent required? In which cases?
So DOT consent is required when you are anticipating problems, mortality issues. Say it's a life-saving procedure. It's a very moribund situation. There you must take death on the table consent. But sometimes DOT can occur unexpectedly.
Yeah.
Many times we've seen PPH cases, the APH cases, fetal distress cases, undergoing surgery, and they land up with the PPH and they die on the table. Those kind of situations you can't anticipate DOT. But in say a moribund case of malignancy, stage 4 malignancy, where you want to create something like a ileostomy or a gastrostomy, you've taken a risk of doing that procedure for palliative purpose. There, of course, you will take a DOT consent. The purpose of taking DOT consent is so that the relatives are, the family is well prepared, mentally prepared for that kind of a situation.
So, in case of DOT, when would you like to declare death?
That's a very tricky situation, no doubt. It's better to initiate resuscitation as soon as you find the problem, and then continue with that resuscitation in the OT as much as possible. And thereafter, you preferably shift the patient to the ICU and continue resuscitation for some more time. And in the meantime, you counsel the family members on the criticality of the case so that they are mentally prepared. And although declaring in the OT or declaring in the ICU matters little,
That's right.
as far as medical legal case is concerned, because if it's an unexpected death,
That's
whether
right.
you declare it in the OT or in the ICU, it becomes an MLC case.
That's right. That means
Yeah.
the police intimation is necessary.
Yeah, the general impression is that if you declare it in the ICU, you don't have to intimate the police. That's not the point. If it is an unexpected death where the issues of the cause of death can be there, or if the family is not satisfied and they are aggressive, it's better to inform the police even if you declare it in the ICU.
Yeah.
But my recommendation for shifting the patient while resuscitating to the ICU is to organize yourself, and you call up, alert the hospital administration, and you make the family a little more mentally prepared. You gain some time.
Yeah. So there was a question that was put by one of the colleagues: is written consent required in cases planned under local anesthesia?
See, local anesthesia is an invasive procedure, no doubt. And local anesthesia may be done for removal of a cyst. Local anesthesia may be required in a critical patient where you are planning tracheostomy.
Yeah.
So per se, local anesthesia is anesthesia, and it's an intervention, invasive procedure.
That's
So
right.
it's recommended to take the consent even if you're doing it under local anesthesia. Any procedure where possibility of a complication is there, it should be done.
Yes.
We have seen
I
deaths.
would
We
like
have
to
seen
add.
deaths under local procedures under local anesthesia.
Yeah,
That's
so I would
right.
like to add here that lot many hospitals have made a blanket rule in their premises that even if a case is to be done under local anesthesia and the anesthesia is to be administered by the surgeon, they have made it mandatory that the anesthetist should be present in the OT for these cases. And it's only in the presence of an
सिद्धार्थ, I'll
anesthetist.
call you after 9 o'clock. Some
It's
web
only
meeting. मैं 9 बजे बाद में बात करूँगा.
It's only after the anesthetist is present and the consent for anesthesia has been taken, and that the surgeon is allowed to, is given a clearance to take the patient to theater. Now, one thing which every surgeon should explain is what is known as local anesthesia systemic toxicity or a anaphylactic reaction to a local anesthetic. Now, both the incidences are described, and it is always better to take consent keeping these two things in mind and then take up the patient to OT.
See, we should realize that it's not only the giving of local anesthesia. There's something more than that. We need to monitor the patient. We need to take care of his vital signs. And when the surgeon is focusing on the surgical procedure, we need a competent person who can monitor the patient.
So who better than the anesthetist can do it?
Yes.
Absolutely.
And there are so many times wherein the patient gets restless in the OT halfway through the procedure, and you need to convert. So if the anesthetist is not around, then it becomes quite a complicated thing. So it's always better to have an anesthetist involved, even if the patient is being done under local and an appropriate consent taken.
I would like.
There's one judgment also on this point, but right now I don't have any citation, but I have read somewhere that the even local can be is to be given by the anesthetist only, not by the surgeon.
So
I will find out that judgment.
I would beg to disagree with that, because giving of local is not so troublesome, and secondly, the surgeon can assess where exactly is the field of surgery, so he is in a better position to give a local infiltration. When we talk of blocks, the regional blocks, of course, anesthetist is more competent, more well versed with those blocks. But when you're giving a local infiltrative anesthesia, the surgeon is in a better position to do that. But it's not a question of giving the anesthesia per se. It is the associated systemic effects which might hamper the safety of the patient. So presence of anesthetist around is always a help. in case you are doing some emergency procedure and the anesthetist is not available, in those situations, it might be a good idea to have any other doctor or any other technician around so that he can monitor the patient and you can keep communicating with him.
May I add something?
Sir.
Now, I am working mainly nowadays with ophthalmic hospitals. Now, there are cases we do under topical anesthesia. Only drops are infiltrated, no block is given. We have blocks and we have general anesthesia. But we take consent for all the three. If it is planned under topical, we take consent for topical also. And we have listed what complications can occur during topical or during local, during general. All these things are taught to talk to the patient. So consent wise and explanation wise, it doesn't matter whether we are doing under topical or block or general anesthesia. Now coming to surgeon or anesthetist giving the block, see, there is no problem surgeon giving the block because surgeons are trained into it. Surgeons are trained to give blocks, so they can as well give block. There is, on the contrary, I can say that most of the anesthetists are not taught how to give block for ophthalmic surgery. We have to learn it from ophthalmologists. So you can't say that anesthetist can give the block and surgeon cannot give the block. In one institution, there was a DNB inspection for ophthalmology, and I was there. And the inspector asked me, "Doctor, do you give blocks?" I said, "Yes, I give blocks." "Do you give all the blocks?" I said, "Yes." Then he said, "How does the ophthalmic resident learn it? When you are giving him DNB and all blocks you are giving, then how does this fellow learn?" So that means they are taught the blocks and they should give the blocks.
There's another question of death on table consent. When should it be taken? In which circumstances? And in case it happens, how and when to declare death? And is police intimation necessary in all the cases?
I think we have covered this.
Yeah. So the complete even police intimation, should the police be involved?
See, when the consent should be taken, there is no doubt about it. It has to be taken in advance. There is no question of when it is to be taken, because if you anticipate, you have to take into that. Now, informing the police is, there are two types of death on table. One is anticipated and one is unanticipated. So when you anticipate, you have already discussed with the people. And when you anticipate, you know the cause of the death. Because you know what can cause the death. Now, unanticipated death has to be informed to the police because it's an unnatural death. It's not a natural death. All unnatural deaths have to be informed to the police. Where two things are there. Death is not natural and cause of death is not certain. These are the two criteria when you are supposed to inform the police about the death.
About the local anesthesia, the surgery plan and the local anesthesia, is verbal consent enough?
Verbal consent is just not enough because how do you prove it? The main thing is proof. Consent is verbal is okay. As just now it was said, legally law says if it there, but if you can prove that verbal consent, it is okay. But how will you prove it later on?
So there's one question which was again asked. If local anesthesia can be given by the operating surgeon, why not spinal anesthesia could be given by him? Similarly.
Yeah. Now, it's a matter of whether the person is trained into that or not. That is the question. Is the surgeon trained to give? There was a time when surgeons were giving spinal, is it not? There was a time when surgeon was doing cesarean. There was a time when he was doing orthopedics. Now he cannot do it because now it is not their training. Everybody is compartmentalized now. So if he is trained, he can give, but he is not trained for that.
Yeah, this is for the people who are still learning. The vital parameters are displayed on the monitor during surgery. So why should they maintain the anesthesia chart? So why anesthesia chart, importance of anesthesia chart, just that is what I think they should know.
What will you produce in the court? You can't take the monitor to the court, is it?
That is right. That is right. So, same question. Another question was, If vital parameters are displayed on the monitor, why maintain the anesthesia chart? Again, I would say for the documentation.
If there is a documentation, it is easier to rebut the allegation of the complainant.
Yes, that is what it is.
One more thing is there, when you are maintaining a chart, say every 5 minutes or something, then it gives an impression that you were with the patient.
Yes, extra vigilant.
If
Yeah.
electronic health recorder is made available, which may
Yeah.
happen in another 4 or 5 years' time, there is no need of physically documenting because the
No.
recording will go on. And that is
Even,
enough a proof.
sir, even now monitors have the provision of printer, but people are not adding it. If you invest on a printer, at the end of the case, you just take a print it out and you can just
Yeah.
put it there. No problem.
For our own safety, we are not doing now, but it may become mandatory very soon. Yeah.
Because people are not, they are buying monitor, but they are not
Yeah.
buying printers.
Yeah. Now this is a question for a code blue happening from the ward. You attend and undertake resuscitation, but are not successful. It is in vain. So who should prepare the death declaration certificate? Is it
The person who has declared death, he has to prepare the certificate.
That is right. So the controversy comes between the person who's come to resuscitate or the under whom the patient is admitted.
Pramod, will it happen? See, a code blue is declared from the emergency. I go there to see the particular patient. I go there with my expertise. I intubate the patient. I try to resuscitate the patient. I do all what I could do in the next 30-45 minutes, but all becoming unsuccessful. Then am I responsible to declare the death of that particular patient or the primary physician who was seeing the patient?
See, on this matter, the court doesn't differentiate whether it's a primary or a secondary physician who has attended. The person who has attended on the patient in code blue and who has tried resuscitation, he will say, now the patient is declared dead. So the person who declares the patient dead, he has to prepare the form. I mean, he can delegate the responsibility to his team member or to the team member of the treating physician, but he remains responsible for declaring the death. I'm not telling about the cause of death, the declaration of death. See, that certificate that we issue to the patient is a death declaration certificate. That's not a death certificate. Death certificate is issued by the municipal committee. So the certificate that we issue is death declaration certificate.
Yeah,
and that certificate has to be prepared by a person who declares death. The treating physician may not be available there. See, the person who has tried to resuscitate the patient and the patient has not been successfully resuscitated and you declare death. So you prepare that certificate.
So shall we presume this way, that whoever comes onto the scene to resuscitate a patient, if the individual finds it's no use to continue the resuscitation, he may jolly well say the patient is dead, no need to go further, and can declare the death and certify. Am I correct?
Yeah,
Yes,
absolutely
correct, sir.
Now the next question is, should all death on tables be reported to police?
That has been covered already.
No,
Death on table?
there is one snag in because all not covered. Because all deaths to be reported. That's my feeling. All deaths on the table has to be reported, whether natural or unnatural. Whatever happens on the table, if it happens with death, well, it has to be reported to the police because it becomes a criminal issue. That is my knowledge.
No,
Geeta may be able to
No, sir.
further.
I don't agree with that.
Code of criminal procedure has clearly said about it that deaths which are unnatural, and that's where cause not certain. It is very clearly black and white in the criminal procedure code.
Sir,
So we
a procedure goes on the table.
Yeah.
Well, some sort of accidental bleeding or a bleeding which cannot be controlled. Patient is bleeding, patient is bled to death. Well,
that has to be reported.
That's an unanticipated.
It's not an anticipated death.
Okay, one thing. Another thing. Well, I am trying to intubate. couple of times I failed, and another friend of mine tried to intubate. Nothing. Patient went into hypoxic arrest. Patient is dying. Who is responsible? Because this also is unnatural, accidental death. Okay,
Yeah, it will have to be reported, sir.
get you reported.
And plus,
I'll come with something else.
it will have to be reported.
Patient is getting
Yes, sir.
amputated. Patient is getting a below knee amputation going on. Out of vasovagal shock, patient is dying. Well, which way you going to put it?
I feel it. This also will have to be
So
reported.
as far as I know, unless a court gives in black and white, every particular death which happens on the table has to be reported today.
No, not only that. No, sir, not that. Because we have just now talked about deaths which can be anticipated, where the risk has been told to the patient, and we know in advance that this surgery can result into death. So
Sir,
those
that
are
is-
not unnatural death, where we
that
know
is
the cause of the
that's
death. We
another
know
thing.
what is the
You are
pathology, and
taking
this is
an
likely to
anticipatory
cause.
bail for that particular matter because you are explaining to the patient as well as to the relations. So this particular procedure may result in some unwanted result. Okay, that means some sort of unwanted sequelae could happen. Well, even in that particular situation, death has to be reported to the police. That's my feeling.
Let the lawyers clarify.
Okay, let the lawyer clarify.
I would like to clarify.
According to me, in every case, it is not necessary. Otherwise, the doctor will not. This is not the. There is no such legal case that every death should be informed to the police.
Not every death, not a death, a patient suffering from fever or a patient suffering from some other disease.
Supposing the person had heart attack and died in the hospital before any operation is done. So I think it is not necessary to inform to the police, because the doctor will give the certificate that because of this reason the death has occurred.
Madam, will it stand in a court of law? A patient who is
Yes,
having
if
cardiac
yes.
disease brought over to the table, patient dies of the cardiac, a massive myocardial infarction or a massive heart arrest. If that heart arrest occurs, patient dies, well, that's going to be proved only through a postmortem. This is what happened, but it has to be reported to the police to do the postmortem even. Otherwise, you will be made responsible. Anyway, that is a practice what we following.
This
The
may
government-
be the practice, but
In the government
according to me-
facility, that is a practice what we doing. In the government facility, forget about the private even.
See, I'll make a clarification here. See, as everybody agrees, in unanticipated cases, if the death occurs on the table, we have to inform the police. No problems with that. In anticipated, where you're anticipating a problem, there, if the death occurs on the table, it is not an unnatural death. It's a natural progression of the disease where
Yes.
surgery was being performed to give palliation to the patient. Then there's no need of informing the police. Of course, you have to take care of your documentation,
Yes,
which
you have to report.
if the patient, if the family wants to take you to the court, you are able to defend yourself.
Yes.
Secondly, if there is a doubt, if a particular situation, circumstances, there is a doubt whether we should inform or not, it's better to inform. But a blanket statement that all deaths on the table be informed to the police, I would not agree with that.
Supposing if the patient has been admitted for surgery, heart surgery, and before that he died, and he had the symptoms of cardiac arrest.
Yes.
That's a natural progression of the disease.
And
You can
if
explain that.
if no documentation
There's no need to
is
inform the police.
rightly reporting everything, then
We don't
I
ha-
think that
We
you
don't have
can
to report
defend
such a
yourself.
case. We don't have to report such a case to the police. Yeah.
Sir, taking our safety in consideration, we reported the
In
police.
every case, you cannot take for safety. You cannot inform every time to the police. You will be involved every time. Police will disturb you. You cannot do other cases also.
No, no, no. We don't have to report such a case to the police. We don't have to report such a case to the police. Yeah.
Yes.
Sir, taking our safety in consideration, we reported the police.
In every case, you cannot
Similarly, when you
No,
have a broad
it
dead
is not
patient,
practical. It is not practical, according to me.
it's not required
Ma-
also. It's not
No,
required.
It is
madam,
not required even.
one,
If you have documented all the things, you can defend before the court if the patient or their relative go to the court.
one thing with this webinar, we must talk
And
about.
you make the history when the patient is admitted in the hospital and comes in the emergency ward.
Yes, here we must focus on what the law requires. What is the practice is different. We are talking
Correct.
of what our law requires from us.
What law wants,
So
correct.
that is what we want. What is
Yeah.
the practice is totally
No,
different. We are not worried about that.
If you are able to convince the court that because of these things, the patient had complication, then you will not be held negligent or deficiency in service.
Well,
The law also,
If you have given the treatment as per procedure and you support the literature with you, then there is no negligence.
slightly whimsical. That's all what I want to comment.
Yeah.
That's
As
all what I
per
want to comment.
procedure, if you have given the treatment,
my
you will
practice-
not be held liable.
From my practice as an administrator, it is better we inform the police. Let the police sort it out. Whether you had to go it for postmortem or whether they're going to settle with their relations rather than you getting involved.
In every case, it is not possible to.
That's why it is said that whenever in doubt,
Whenever in doubt, approach the police.
inform. That I agree. Whenever in doubt, inform the
That
police.
much
I
is
agree
acceptable.
with that.
That's what I was trying to go in because
That's
you
right.
cannot say whether it is natural or unnatural at that particular point of time.
That's right.
Yeah.
So
And
it's
another thing, do we
yeah.
need consent for blood transfusion?
Absolutely.
Yes,
Transfusion
yes,
or
yes.
Absolutely
or
must.
platelet transfusion or cell transfusion or whole blood transfusion or any blood product transfusion.
All blood product transfusions.
You need
Blood
a
or blood product transfusion. Well, people
Yes.
should be aware that consent
Yeah.
has to be taken from the patient.
Taken, yes.
Yeah.
No doubt about it.
That's not for blood alone or for all blood products.
All blood products.
How about serum immunoglobulin? I'm coming to a different area. How about serum immunoglobulin?
I think that also. Is it 100% safe?
It's
No
not written
complication,
anywhere.
nothing?
When you land into a problem only, you're going to find across.
No, so before landing into problem, why not take a consent? It's a very
Consent
simple
is-
job. Why
I
get
think,
into the difficulty? Taking a consent is so
Yeah.
simple. Do
I
that.
believe Harbhajan wants to talk on this particular matter. That means
Yeah.
blood,
Let us
blood product
listen to.
or serum. Do you think consent is
See,
necessary?
the thing is, when it comes to a heart transplant or kidney transplant, people are very serious.
Yeah.
People don't realize that blood is an organ in the body. And blood is a very, very important, and it is very well recognized by the Organ Transplant Act. So you have to take consent for blood transfusion. It is so simple. What product is there? RBC or platelet or FFP doesn't matter. And as regards immunoglobulins are concerned, I think if we consider the source of origin, how they are made, we should understand that there is a chance of having an allergic reaction to it, which can kill the patient anytime, sometimes. So it's always better to take an informed written consent before giving immunoglobulins as well.
Blood or blood
The-
product or globulin. Yeah.
But the point is, our discussion is dilemmas in anesthesia. So do we give immunoglobulins in anesthesia?
Yes,
I need to-
some days you will be forced to give them immunoglobulin there.
I'm yet to see it being given in the operation theater, sir. Maybe I need to work more.
Yeah.
Very common, yes.
Okay, maybe.
So on next question on code blue call from the ward. You attend and undertake resuscitation, but it is ineffective. So patient dies.
That is
Whose
discussed.
responsibility?
This has been covered.
Discovered.
This is
Yeah,
covered.
discuss this, na?
This has been discussed. Okay, just come as a 9th question. That's why probably I got it. Okay. Since the patient approaches the surgeon for treatment and anesthetist is selected by the surgeon or hospital, can the patient allege negligence directly on the part of anesthetist, or will vicarious liability come on play in the case of deficiency of the anesthetist work?
Will you read the question once more?
You know, it is a question on vicarious liability of the surgeon for something that goes wrong on the part of anesthetist. So can the patient allege negligence directly on the part of anesthetist, or there is vicarious liability in the case of deficiency of the anesthetist? That means
I think
vicarious
the
liability by
law
the
is
surgeon.
very
If
clear.
there is a fault on the part of the anesthetist, and
Yeah.
there is and the wrong has been find out on anesthesia, then the
If that is
anesthetist
found
can
out.
be, yes. And if there is any deficiency in service on the part of the anesthetist, then the anesthetist can be, because the reason is written why this complication has come.
Yeah. Sometimes
Has
it will be
occurred.
massive hemorrhage. What I'm actually saying, when
Yes.
it is a massive hemorrhage, then probably it will be mainly
If it is related to
accident.
Madam,
anesthesia,
madam, it is debatable.
That's
The
right.
surgeon will always say the massive hemorrhage happened because anesthetist was not diligent in administering the drugs required and taking the measures to stop the bleeding or dilute the bleeding. Okay, that means that may be the argument which is coming against you.
May I clarify?
Yeah, please.
Surgeon has to deal
See,
with.
this vicarious liability, the principle of vicarious liability is that although you have not done any wrong, but you have hired a wrong person. So the question here is whether the person is anesthetist is working as an independent consultant or he is working under instructions of the surgeon. That is the question we have to answer. So vicarious liability is because you are hiring an incompetent person. That is why you are negligent.
That's right.
So if you are working as an independent consultant, then direct liability is yours.
Yeah.
Even if you are working on a salary, you can't escape your liability. Although the person appointing you also will be vicariously liable, but you cannot escape liability. So that principle we must, who exercise the control? Is it not? For example, you go in a taxi, the taxi driver is driving, that time he is responsible. But if you have your own car and driver is driving under your instructions, then you are vicariously liable.
That's right. So we come to the next question. What is res ipsa loquitur and when is it applied?
See, when the res ipsa loquitur, yes, anybody can answer.
See, res ipsa loquitur is a doctrine where the thing speaks for itself. And it has to be so obvious that the situation or the effect cannot be without a negligence happening.
Yes.
Like you operate on the wrong patient, you amputate the wrong leg. Then there's another ingredient which says that the control of the decisions, the control of the action was on the respondent. Normally, it is the complainant who has to prove the allegations. In res ipsa loquitur, if that is activated, the burden of proof shifts to the respondent. If something happens in the surgery, in the operation theater, the patient, the family, the complainants, they have no access to the operation theater. Everything is happening in the closed doors. So if something major happens there, as for example, a walking patient, a small procedure, he goes in and after a while he is brought dead. Something wrong has happened in the operation theater and the complainant has no access, the family has no access to what happened in the operation theater. So in that situation, the control was purely on with the defendant. So the courts can activate the res ipsa loquitur and the burden of proof then shifts to the respondent.
Where there is a presumption of negligence.
That's presumption of negligence. I mean, things speaking for themselves. Say during a laparoscopic cholecystectomy, you injure the colon as well as the CBD in a simple, straightforward cholecystectomy. So it means something wrong has happened. And the complainant will not be able to find out what wrong had happened. So the court will, shift the burden onto the respondent to explain your innocence in the matter. There may be situations where they are able to explain have a proper defense, so they'll be acquitted. But if they're not able to explain why the thing had happened, so they will be held negligent. It's a
In one
question of
case, and in one case, the patient was died in OT before operation within an hour, and her reports was okay before operation. Then the court presumed that there was a negligence. That is why the cardiac arrest has happened.
The cause of death?
Cardiac arrest.
No, cardiac arrest can happen due to anything. Even it could be, a reflex mechanism of the nervous system.
But she was not
Postmortem?
hypertensive. There was no, all reports were okay.
Okay.
So
See,
immediately,
essentially-
the patient had the cardiac arrest. The court has held that there must be some negligence on the part of the doctor, because doctor could not explain, as Dr. Kohli said, that if the doctor fails to explain to the court
That's
that why that has occurred, so
That's right.
yeah, if the
Correct.
doctor is able to explain why this has happened, then there is no negligence.
Yep.
so
I agree.
essentially
But
it is a
in that case, the doctor could not explain why the patient has died.
Mm-hmm.
But before the operation, all reports were okay.
Yeah.
There was no instances of any hypertension and other things.
Ma'am, there are some things which are very
Causes.
difficult for the
Mm.
law to understand.
Mm-hmm.
See,
Yes.
absolutely normal person having all normal reports can have a
Yes, I
syncopal
understand.
attack
I
anytime.
understand, but I am
So-
talking about
Yeah.
the court order.
Yeah, that's
No,
exactly
but was
what
the
we need to
postmortem
understand.
done? Was the
So
postmortem
you
done?
have to tell the reason to the court, and to satisfy to the court, you have some material with you that why this has happened. So at that time, you have to documentation all the things.
No, I would say that sometimes, there could be probably, as you said, documentation. Suddenly there's a heart irregular beating or anything, or due to whatsoever reflexes or what happened. So definitely it is very difficult to say unless there's a rhythm noted there and
Hmm.
taken
The reason can be explained by the doctor only, na?
yeah, that is thing. And I think in all such cases, postmortem is
Court
also
is
done.
fine. You have to give the material to the court to satisfy.
Yeah. Differential diagnosis, yes, what happened.
Therefore, the doctor has to be very careful about all the things, and
That's
and you have to declare the death, and you have to report in the files also.
That's right. It's an unexpected death, and you have to find the reasons for it and also give your differential diagnosis why it could have happened.
Hmm.
I agree with it. It has to be documented.
See,
And even if
essentially,
needed-
let me make a point. Essentially, it is a rule of evidence.
Yeah.
It does not establish negligence.
Oh, it only shifts the burden of proving
just shifts the
negligence. It
burden of
shifts
proof.
the
Yeah.
burden, that's all.
Exactly, yeah.
If without any evidence, the court has come to the conclusion that the doctor cannot explain, then this doctrine applies.
Right, you are right, madam.
you are very right. So what is
Next
res
question.
locuta? Did we talk about it?
That is what we have been discussing, na?
And soon that only we are discussing.
So we don't have to do it separately. Again,
नहीं,
it's
अभी
an-
हो गया ना, that question only has been answered na just now.
तीन question और रह गए. If
बोलो.
an OT mishap occurs due to an instrument failure, say electric cautery or an anesthesia instrument like laryngoscope or oxygen supply, who is responsible?
Management of the hospital.
As well as the hospital.
Yeah.
And also
If
the
it has not
anesthetist,
been
I mean,
checked- if it has not been checked before operation and there is no alternative.
Mm-hmm. That's right.
Huh.
I think I would like to come in and make two things very clear, that for some things there is a responsibility of the management, and for some
Yeah.
things
Yes.
there is a responsibility of the person who is the end user, the surgeon or the
But
anesthetist
who
in the
will
OT.
inform the hospital that this machine is not working?
Madam,
And there should be a spare-
no,
a
listen,
spare
there are
machine
two things.
also.
Yeah, Geeta ji, there are two things. Before starting a surgery, everything can be absolutely fine. Okay, and any machine can malfunction anytime during this surgery.
Yes,
Even if
yes,
you have a
that can
AMC
be.
done, yeah. So the point is, when things go wrong, you have to have a backup plan executed. So
Yes,
before starting a case, you have to put it in your records that at the time of your pre-procedure checklist being done, you have inspected that the AMC is in place, the machines
yeah.
are checked, they are found to be okay as per the checklist given by the manufacturer of that equipment, and that a AMC is in place. Now, this is what you have to document. After that, you also have to document that in case this machine fails, what are you going
Yes.
to do? Do you have that backup? Yes. And when it happened, you executed the backup plan. Now, if in
This is
spite of
important.
doing all these things, you are not able to save a patient, then I don't think the anesthetist or the surgeon is responsible for it.
Yes.
So you have to be able to defend yourself that yes, when things went wrong, whatever was supposed to be done, you did it as per the standard protocol
Yes.
which has been
Yes.
defined in the organization.
This is basic. If you are able to explain to the court that I was vigilant, I have taken care of all the machineries,
Yeah,
then I think you will not be held responsible.
absolutely. So for the maintenance of the machines, it is the responsibility of the management to make
Yes.
sure that whatever equipment they are giving in the OT, they are well maintained, they are under valid AMC at the time of use. If the
Yes.
opposite party is able to prove that whatever equipment was used for their surgery or anesthesia was not having a valid AMC, then you will end up in problem. So that is the
Yes.
responsibility of management.
How the
Yes.
valid AMC comes in? How the AMC comes into question here?
MCS.
Sir, according to the NABH and JCI accreditation, you
And
have to have.
don't go into NABH. The reason why I'm telling is that whenever
No,
you are
no.
going to give, you check the machine whether the machine is in proper order and find out whether you have a backup machine. You don't have to look into the AMC or not. AMC is with the management, and the management looks, or the NABH who is accrediting the hospital looks whether they have the AMC. Not with us. We have nothing to do with the AMC. We have only one thing: when we starting a procedure, see the particular machines involved, instruments involved, drugs we going to use, all are available and of good quality and in good condition, and we have the backup facility also. That's all we are concerned, nothing more.
Sir,
I
absolutely.
agree. I agree.
Ultimately, you have to find a scapegoat. So, who is going to be the scapegoat when a
Scapegoat, let
machine
anybody be
malfunctions?
scapegoat. Let anybody be scapegoat. Because NABA says that in that particular situation, a hospital has to have the AMC with themselves to see that their system is in proper order. That's the reason. But we are not responsible.
Absolutely.
Yes.
That's what I made it very
Yeah.
clear that it is
You are
like this.
responsible only if you have not checked before the
Correct.
use.
Pre-procedure check. Pre-procedure
Absolutely.
check has to be done.
Absolutely.
It is required and you have not checked
Yeah.
before that.
Yeah.
Suppose the equipment has been checked, but there is a failure of that equipment.
You have to go with the backup equipment. You have to have the backup equipment, not with one machine you are going to.
That's what I'm saying. And if the OT mishap occurs due to instrument failure and the things go worse for the patient, and you don't have a second backup machine, so who is
Then the
responsible?
hospital is responsible.
Hospital, second,
No.
backup machine has to be there when you start something, or
Yeah.
some sort of backup bailout system has to be there.
Has to be there.
Something else has to be
Yes.
there.
You can
Not
loan
a machine all the time. We may be able to survive even with some other equipment, but it has to be there. It has to be there
You're very right.
because there are plenty of anesthetists goes around in
That's right.
circles,
Nursing home.
peripheral Sundays, and they do it. They're
Mhm.
taking that particular risk, but they know if the equipment is failing, they have something with themselves. They
Yeah.
may be able to survive the situation. Yeah.
That's
And
right.
if after demand it is not provided backup, then the hospital only is responsible.
Becomes responsible.
Correct.
Yeah.
That's correct.
You have to prove that you have to ask for it many times. Okay. Now there's an anesthetist who got a call from a nursing home for a surgery, say for removal of uterus, total abdominal hysterectomy. Now, what will be the response if you realize that the surgeon is an Ayush doctor? Their OT does not have multi-para monitor where it can monitor well. There's no doctor available for postoperative care, and they have not cleared the anesthetist dues despite reminders.
Well, I doubt whether it is coming into our realm.
It
Whether
should.
it's
I
not
think
coming.
it is coming from
It's a very
private
valid,
practitioner forum.
It's a very,
it's a
very
very,
vague
very
question. It's
valid
not coming
question.
into our area now.
It comes from private practitioners forum.
Yeah.
No,
Yes,
So
see, one thing is very
valid question.
clear. If there is no monitor, there is no question of doing a case.
doing a case, yes.
It should be very clear. Who will
And
do
it
a
is
case
not
without a monitor now?
And then if he is going for a surgery and he realizes Ayush doctor, now once you have started, it's too late.
Now Ayush doctors have been authorized by government now.
Exactly,
Yeah, the
exactly.
So you
government,
are-
the government will
Ah,
look after. Don't worry.
no.
That's right. That's right. I agree.
So that's not a problem.
Mhm. Again, this is the
So-
last question. You are a head of anesthesia.
Again, one
in a
thing more before you go for that.
Huh?
I may like to say the government of India, even today, as on 3rd March 2021, has not made it mandatory that a defibrillator has to be there in an OT. Even today, it has not been done. Okay,
That's right.
that's the situation where we are.
That's right. Yes.
Because
Right.
we say something, we practice something else.
You are very right. You are
When
very
we
right.
accept, well, a lot of compromises everywhere.
Yeah, and then rush our technicians to
Ah.
fetch it from the neighboring
Yeah.
ward. Yeah, you're right. Okay, this is the last question. You are working as a HOD anesthesia in a corporate hospital. You have repeatedly requested the management for taking an AMC of the Boyle's machine. In the absence of maintenance services, what should be your stand for taking up elective cases?
Leave the hospital.
Exactly. If a machine-related mishap occurs and the agreed family has filed a civil and criminal case against HOD of anesthesia.
Yeah. To avoid
this-
vicarious responsibility, leave the hospital at the earliest.
That's right. So I think that concludes our panel discussion here.
Sunila, I have one question
Yeah.
for our lawyer panelists.
Yes.
Yeah.
And
What?
my question is how does the court fix compensation in cases of negligence?
Depend upon the person, a loss of it depends upon if the person is a main person in the house and there is a loss of financial, then on that basis the compensation is fixed.
How
If
do they
suppose a
calculate?
person who died and is the only person earning in the house, how much he was earning, and if there is a lady and there is two small children and there is loss of love and affection of the mother, the court decide according to the facts of the case.
It's a
Now,
compensation.
my question is that you are deciding compensation based on the earning capacity and future earning of the person who died.
Yes.
Right.
Earning, and if the wife is not earning and she died leaving two sons and the whole family is disturbed, the compensation is fixed for love affection and the being a mother. The court decide.
No, I am talking about you decide based on future earning of the person who died.
Yes.
How many working years he still had and how much he would have earned. Is it not?
It can be considered. It is considered.
No. Is it considered? This is considered. So now my next question is, suppose something happened to Mukesh Ambani, who can pay that much? his future earnings can anybody pay? So I feel that this system of compensation is not okay. It's not fair to the doctors. There should be some cap or some other system of calculation, because the patient might be earning anything. How does it affect doctor? Doctor, he is not paying doctor that much. There should be some
criteria. But
no, but you tell me if something happened to Mukesh Ambani, what will go through?
Let God save the doctor. Now, I have one more question to Dr. Geeta. Sorry, Geeta. The question is, well, choice of anesthesia. I am a single practitioner.
Yes.
I am going to a peripheral area. I am supposed to give anesthesia to a patient. I say to the patient, well, general anesthesia, or I may not be able to put you to sleep. I may be able to give only a local analgesia or a regional anesthesia. I may be able to make the area numb, or I may be able to make the area pain free, so that surgery could be done. The patient is not willing. Patient says, I want a complete anesthesia in the times of the patient, or say, I would like to sleep during the patient. That means patients want general anesthesia, but I am prepared to give only regional anesthesia, or say spinal anesthesia or local anesthesia, whichever name you want. So there is a
That,
there is a
in that
conflict.
case,
Yeah.
in that case, you can explain to the patient that I will not provide, I will not administer the general anesthesia.
Yeah.
And you have a choice. Then he may give consent. Then you can give the local anesthesia. And if he does not give any consent, then you can avoid that.
You
Discharge him, huh?
can simply escape this area, you mean, isn't it?
Yeah.
You can simply escape the situation.
Yes.
That's only thing.
One more question to the lawyers, because it's a principle that whatever is documented has been done, and whatever is not documented has not been done. Okay. Now my question is, if everything has been documented but not done,
In that
I
case,
make
if
a
you are-
very perfect document record of case and everything, but I have not done it.
No, the consent is very much required, except in emergency cases. And if you are able to explain to the court, because of these things, there was an emergency, I cannot documentation, but I had explained to the patient.
No,
And
no.
they,
I have documented, but I have not explained. I have documented, but I have not explained, because document is weak in the court. So if I have documented something, but I have not done it, then what do you do?
No, if you are
Because
not
you
able
go
to-
by documents only.
If you are not able to explain and the court is not satisfied, the court comes to the conclusion there is a hanky-panky, then the court, because in your defense, you have to sometimes support the literature also, that this is the accepted procedure, which I have adopted.
No, I am not talking of that, madam. You understand, my question is, I make the documents look perfect, but I have not done it. That is the thing. The court goes by the document, not by
Yes,
what I have done.
Definitely.
See,
That is my question.
may I attempt to answer this?
Yes, sir. Please.
There is a thin margin between smartness and fabrication.
हाँ, मुझे बता दें.
Ah,
So, if the complainant is able to prove that it was actually not done, but it has been documented, and the court is convinced, that will come under fabrication or cheating.
हाँ, मैं आ जाऊँगा URS पे.
Otherwise, it is
बता देना
smartness.
मुझे.
yes.
हाँ, मैं
It
Because
is a question of satisfaction of the court.
15 minutes.
If you are satisfied to the court, this is the duty. If anybody lodge any case against you, then in defense you have to rebut all these things.
That's right.
There's no
No.
question of that I am not able. You, your counsel will. You have to engage a very good counsel who can explain on your behalf and find out the literature also, like me. Sometime I find out the literature for the doctor and the hospital.
That's why we are approaching
I have
you,
to
Geeta.
advise.
That's why we are coming to you.
Right. I think the last
Sometimes
question.
I
after this.
have to learn the medical also.
Yeah. Okay.
Sometimes
Huh?
I have to go through medical literature also.
Yes, definitely.
Correct,
You have
correct.
to.
That's correct. That's
You have to. Everybody, like we go through the legal literature many times.
Only then I can contest the matter on your behalf or the behalf of the hospital.
Organization. Definitely. Now the last question coming. You are working as
This is
the
the
head of
answer.
department. Head of department anesthesia in a corporate hospital. You have repeatedly requested the management for taking the annual maintenance contract.
that is
of the
discussed.
anesthesia machine.
Discussed.
Okay, na, it is done already, Sunila.
अच्छा ये
already.
तो बोला ही नहीं
It is
मैंने, ये तो
already
last
discussed.
question था.
No.
नहीं ये तो हो गया ना अभी डिस्कस हो गया now if
अच्छा इसी में ही
the
हो गया,
questions
ठीक है.
are over you
Yeah.
can
नहीं,
open to the
That
you
will
can
be
open the audience for some
that will be
questions
your
if you want.
discussing. Yeah.
But I don't have either any questions coming, but let me see. 9 new notifications.
So
No,
now you take questions from the audience now if possible.
Note in the
Okay.
chat box. Note in the chat box. Any question in the chat box?
I think the
No, I
questions
don't.
have been covered.
Yeah, then it's okay. I
Yeah,
think we can.
there was one question asked by Dr. Namrata Nagratna regarding taking up a patient with deranged renal function test with due consent and patient dying later on in the post-op period. So will the anesthetist go to the court in this case? I would like to respond to this that if you have explained the reason for renal dysfunction and if you have taken all the precautions to ensure that renal protective interventions were done during this surgery and they were carried on effectively in the post-op period, then there is no reason that anyone can hold you responsible for the deterioration of the renal function. That could be a part of the ongoing medical disease, or that could be a part of the ongoing surgical disease itself, and not responding in spite of intervention. So anesthetist cannot be held responsible. You will have to prove that you made sure that the patient received adequate hemodynamic protection during this case. Patient received good amount of fluids. You never allowed the BP to crash. If you can prove all this, then there is no way that the anesthetist can be held negligible for medical negligence in this case.
There can be a
The
catch
question
here.
comes, if you are able to explain to the court, then there is no negligence.
See, there can be a
And the
catch.
court is satisfied.
Yeah, the court never goes with what is right. Court goes with what is
What is the
proved
catch,
to be
Pramod?
right. So we
The
have to
catch
be,
is if you have not mentioned the raised parameters in the PAC,
Yeah.
you have not documented in the anesthetic check, then you will be in problem.
Yeah, you may land in problem. Yeah.
Yes.
Can I interrupt? Can
Therefore, it is advisable that you have to record all the things in the files.
Yeah.
yes,
Yeah,
actually in the informed consent, as sir has already mentioned, there is a discussion and there is a decision making. So
Yeah.
in the discussion part, you have to clearly write that this patient is having elevated urea creatinine, possibly because of these reasons. And this patient is likely to have these complications irrespective of the medical intervention that we are doing. So if you have documented it very nicely and explained, then I think there is no reason to worry.
Yes, yes.
But the
So it
second
is
part
very
is
important
just
for the
because,
doctor to record each and everything.
yeah, but this does not give you an immunity to do all any nonsense in the theater. If you do not pay attention to the patient having low blood pressure, if you do not pay attention to the patient having fluid and electrolyte disturbances in the OT, if you don't document it in your record, then you can be held responsible for it, even if the
Yes.
patient has been
And you will
explained
be
and consented to it.
yes, in a difficulty.
Yeah, can I talk?
Yes, please.
Yeah, yes, I'm Dr. Nagaratna. So actually what happens is here, like the surgeon wants to push some amount of the thing on the anesthetist. Yeah, in spite of knowing like instead of doing it for 3 hours, they do it for 6 hours or 7 hours, even the duration of surgery counts. But still, like there was a mortality meeting regarding this. And he pointed out one point like, okay, during induction, the pressure fell down to 60. Okay, but like it was immediately taken care of. Okay, and even the urine output like pre-bypass was there, like 150 ml was there. So if there is a proper documentation, we need not worry, right? But still, like they try to drag us also. That is the reason I was telling.
Yeah, one advice which I would like to give to all the youngsters is that you guys need to be mentally strong. You need to be able to defend yourself no matter how senior or arrogant your surgeon is, or how high he might be positioned in your organization. This is one. And
Yeah.
second thing is there is something called WHO surgical safety checklist, which we all follow. And in that, there is a clear column which says what is the expected duration of surgery. So if the surgeon says that he's going to take 3 hours for that case, now under any reasonable wisdom or circumstances, this surgeon can take up to 4.5 hours. But if he's taking 6 hours, make sure that you have a critical instance form filed from this surgeon, and in RCA done as to why he took 6 hours in this case when he had said he is going to take only 3 hours. You need to do this exercise regularly, no matter how good friend that surgeon might be to you. Have it documented that for 3 hours procedure you took 6 hours. So what were you doing in the OT? What were you playing around with? What was the complication that you were dealing with, or what was the difficulty you are dealing with? These are the things which will come to your help.
Well, Harbhajan, 1 point.
Okay.
Yes.
Somebody says 4 hours he may be able to do, but
Yeah.
he completes only in 12 hours time.
Yeah.
That means 3 times more he was taking.
Yeah.
And do you think by raising an incident report, probably NABH may be asking a question, why it took that much of time?
Yeah.
Only NABH, not the management, not the
Sir,
police, not the court.
it is the responsibility of HOD of surgery, or it is the responsibility of chairman surgical sciences, or it is the responsibility of the medical director to investigate into this case, that if it was to get over in 3 hours, why he went on operating for 12 hours. It means something has gone wrong. So we
Well,
need to find out what went wrong and who is responsible for it, and that these things don't happen in future. What can you possibly do? What do you learn out of it? That's the idea.
In fact, what went wrong should be part of the operation surgery notes.
This incident reporting, is it legally acceptable? That's what I am asking.
It needs to be written in the
Because-
notes. What
No,
went
it
wrong.
can be written, it can be put up, because an RCA could be found also.
Yeah.
A root cause analysis
Cause
could be
analysis
made
has to
also.
be done.
But will it have any much effect other than with the NABH accreditation purposes?
No,
Obviously,
even
it will
not
have.
only save your skin.
Yes, a
If the
meeting which
management
you,
wants to blind on that particular matter, well, it is going to be like that.
No, but we must document because we have to save our skin. We are not bothered about who is doing what.
You're
we
going to have an
should-
unfriendly relation, kick it up.
No, there's no unfair because
sir,
if
there is
something
no
has
need to be
happened due to
friendly in the
sudden.
OT. Ma'am,
So
please
in
allow
OT,
me to
suppose
come
there's
in.
a big vessel that is cut accidentally. We do record it on our anesthesia charge that this happened and so much
The
of
vessel cutting and all recorded, but for a simple procedure, which usually being done by anybody, let's say in 4-6 hours, somebody taking 12 hours, that means nearly 100% more time.
Yeah.
I
This
think,
act,
I think it is criminally.
yes. This actually goes when we go to the quality measuring meetings.
It's
There
only in
this
the,
is
it comes
discussed.
only in the quality part.
Yes, quality
Only in
assurance
the
part it
safety
comes.
and quality part only it comes. And
Yes.
as Harbhajan was telling, that is an NABH requirement
No.
also. It has to be certified that way.
Yes.
But whether this incident reporting and finding a RCA is of any purpose, that's all what I
Yeah,
doubt.
definitely, definitely, sir.
Internal
If
purpose,
there are 10 incidents reports of a surgeon taking long time,
Yeah.
that will definitely go against him in the court of law. There will be at least a group of 4-5 people doing an RCA in any hospital
Yeah.
of different specialities, not just the surgery and anesthesia. And when there are so many reports available that the surgeon is always doing this kind of thing, and ultimately court only goes with what is documented. So how do you
Not only
document
court,
that a
the
surgeon is
hospital will
having?
also go. Administration will also take action.
Administration, if they want, they can change the
They
surgeon.
can change. Yeah.
Change the surgeon. And the government, no change even possible. Only thing the head of the department made me
Retired.
maybe retired by the time any action comes in. But if the head of the department is really robust, in that case, he may say, well, sir, don't go for that particular procedure. You are not
Sir,
supposed to go for that particular procedure.
that's fine.
You could be put off. Yeah.
Trust me on this, sir.
Yeah.
One second piece of advice that I want to give all my colleagues is that, like you said, that this will result in an unfriendly relationship.
Yes.
Sir, we are professionals coming for professional work in an organization, in a
That's right.
theater. We are not here for friendship. We are here for professional work. If I am standing on the head end, I am an anesthetist. It doesn't matter what my age is, what my position is. I am responsible for that patient. I am going to do what is right. I'm not going to do what is friendly to this surgeon. This is one concept which we Indians have to get it very right. This is where things go wrong. Why should I be friendly to any surgeon? There's no need to be friendly.
Last
You need to be
sentence I
professional.
accept. We Indians has to modify ourselves. on
Absolutely.
that
This is
matter.
what is
I
faulty in our
agree on
training.
that particular matter.
Yes.
Because this may not happen anywhere else. Here only compromises comes in. Yeah.
Sir, it's a different ball game in a medical college, in a government hospital, and in a private corporate hospital. The dynamics are different. And the day you step into a private hospital, you realize that it's a different world. You are accountable and for each and everything that you say, that you do, that you write.
It's a different. I agree.
Absolutely. There are some things which people in the government medical colleges and hospitals will never understand.
Yes.
Right.
Thank you, sir.
Dr. Jayashree,
Yes.
yeah, will you please come in?
Yes, I'm very much here. And good evening, everybody. And I must thank everybody for this very, very lively discussion and this webinar. Dr. Radhakrishnan was very keen that he should have it. And I told him that you have actually taken the Delhi people away from us and put it in the Trivandrum slot. And such an exciting webinar. Thank you so much, Sunila, for it. And, you know, you've selected absolutely the cream in medico-legal speciality. And I would like to thank Dr. Parakh, Dr. Kohli, Dr. Saini, Geeta, and Dr. Urvashi. Really, it was so good. And of course, since we are all there in the, at least I'm in the private sector, and we have so many of these, we all have medico-legal hassles, whether it is private or government, but surely in the private, it's much more, as Dr. Saini was saying. And I think that's the thing, that documentation is a must. And I would really like to thank all of you, and thanks a lot for really coming today in this webinar of the Indian College of Anesthesiologists. Thanks a lot, and thank you, Sunila. Thank you very much.
Thank you.
Dr.
Thank you.
Radhakrishnan, thanks a lot.
Thank you, ma'am. Thank you.
Thank you. Thank you.
Thank you,
Thank you
everyone.
all.
Thank
Thank
you,
you all for
everybody.
joining us.
Good
We
night.
all,
Thank you,
Thank
Dr.
you.
we all
Thank you.
enjoyed, really enjoyed.
Yes, we
Thank
all
you.
enjoyed a lot.
Good night.
Thank you very much.
Looking forward to
Thank you
more.
for such
Thank you.
beautiful
Thank you,
replies.
Dr.
Thank you.
Nagaratna.
Very good
Thank you
discussion.
very much.
Thank you.
Thank